Bismillah ar-Rahman ar-Rahim. Assalamu alaikum everyone. I hope you guys are doing great and your preparations are going well. I'm Amro Hajja, fifth year medical student, and today, inshallah, I'll be presenting one of the most interesting topics in renal. Honestly, it's urology practice questions. Urology is a little bit, might be a little bit difficult because it's a clinical subject. However, it's like straight to the point and they won't ask you difficult questions. So most of the answers are going to make sense to you, and inshallah, we'll go through them together as we move on. So I tried to go over all your urology lectures and to identify the most important and the high yield concepts, and I put some questions on them. The way I'll be doing this presentation is that I show you the question and then the answers, and I want you to pause, answer the question yourself, and then we can I'll show you the answer, and then we'll discuss the concept in 1 or 2 slides. So let's get started. The first question is, a 30-year-old man comes to the physician because of sudden right-sided flank pain, nausea, vomiting that started 4 hours ago. The pain radiates down to the groin. He has never had any similar episodes in the past. He states that he doesn't drink so much fluids or liquids. His temperature is 37.3. Pulse is 100, respirations are 18, blood pressure 150 over 92. Physical examination shows a soft, non-tender, and non-distended abdomen. There is tenderness to percussion at the right costovertebral angle, and this is basically the urine analysis. Now, I want you guys to pause the video, try to answer the question, and we'll go through it together. Okay, I hope you answered it correctly, but let's go through it together. So let's see. Here we have a sudden right-sided flank pain. Okay, sudden right-sided flank pain that radiates down to the groin. So this is basically a typical presentation of loin to groin pain that's happening in a 30-year-old, an adult male. Okay. Other clues in the question are basically here we have the guy stated that he doesn't drink so much fluid. The rest of the examination is not like it might be helpful, for example, the right costovertebral angle. However, everything in between is not very important to us. So here we have a typical presentation of a loin to groin pain in a young adult man with this basically urine studies. So what's the diagnosis that you're thinking of? Exactly, it's kidney stones. Now, what's the most appropriate next step in the management whenever we have a patient with kidney stones? It's going to be a non-contrast CT of the abdomen and pelvis. Why is this the answer? I'll explain it to you in a bit and then go back to rule out the other answers. So let's start here. Here we have a KUB X-ray. KUB X-ray is one of the diagnostic modalities for kidney stones. However, it's not very commonly used and it's not used as the initial step, and it's also not the gold standard. Why is this the case? Because we have multiple types of kidney stones that we're going to discuss later on. And some of these types, they don't show up on X-ray, which means that it has very low sensitivity compared to the CT, which is why we don't use it as the initial diagnostic modality. Here basically showing in an ultrasound, this is basically here the kidney, and here we have a stone, which is highlighted in the red. We have a kidney stone. Ultrasound can be used in diagnosing kidney stones. However, it's used in certain conditions. For example, if we have a pregnant lady, this pregnant lady can't be exposed to that much amount of X-rays in the CT, which is why we do an ultrasound for this lady. Another scenario is if we have a child. So usually we don't like to expose children to X-rays, which is why we don't do for them CTs unless it's very indicated. And in this case, we would use an ultrasound. Lastly, here we have an IVP, intravenous pyelogram. It also can be used in the diagnosis of kidney stones. However, I wouldn't say that it is the initial step, and it's not the gold standard for the diagnosis of kidney stones. So we're left with the non-contrast CT. Let me just erase. Okay. So we're left with the non-contrast CT. Non-contrast CT is the initial and the gold standard modality to treat kidney stones. Why? Because it has very high sensitivity, which means that most of the stones are going to appear in the CT scan. As we can see here, basically, one of the stones that's appearing. An important thing to consider is that it's a non-contrast CT. Why non-contrast? So if we had another another answer and another option here, which says contrast CT of the abdomen and pelvis, it's wrong. It has to be non-contrast. Let me show you why. Let's say that you give contrast, and now contrast will go all the way, contrast will go through the arteries, will go all the way into the kidneys, and then it will be excreted, it'll go into the urinary system, in the renal pelvis, the ureter, and go all the way to be excreted by the bladder. So whenever there is a contrast, it will show in white, and the stone is showing in white. So this would basically cause mask effect on the stone and would basically not allow us to see the stone, which is why we don't use contrast for the kidney stones. So this was basically about the first question. Now let's move on to the second question. Here we go. A previously healthy 31-year-old man comes to the emergency department because of an acute onset left flank pain radiating to the inner groin. Acute onset radiating to the inner groin. He has also had nausea and an episode of hematouria. He appears uncomfortable and he is vitally stable. There is tenderness in the left costovertebral area. CT scan shows a 4 millimeter stone in the left distal ureter. They started him on fluids, and they started him on tamsulosin, which is an alpha blocker, and ketorolac is also initiated. We're all good until now. So 5 hours later, he passes the stone. Metabolic analysis of the stone is most likely to show which of the following. So I want you now to pause and then answer the question. I assume you did. And now let's move on to show you the answer. So the answer here is calcium oxalate stone. Why is this the case? Basically, there is no clue that would tell you that, oh, this is calcium oxalate stones, because you guys know that, for example, in cases such as hyperparathyroidism, hypocitraturia, as we are going to explain later in the next slide, these are all causes of calcium oxalate stones. Okay. But in the question stem here, we don't have any of these any of these obvious causes. So this question, what is it addressing, is that it's addressing and it's asking you for what is the most common, what's the most common constitute of the kidney stones. So out of all of these, A, B, C, D, and E, the most common constitute for the kidney stones is the calcium oxalate, which is why basically the answer here is calcium oxalate. As you can see here, the question is asking you what is the metabolic analysis of the stone most likely to show, and in the question stem there is nothing indicating which one of them, which is why we went with calcium oxalate. Now let me just give you a brief idea about the others. Uric acid usually found in patients who has gout. So in the question you would find a patient who usually has gout, who has flares in the past, and all of these stuff. So calcium phosphate is one of the rare causes, and it's not very commonly seen. Magnesium ammonium phosphate is what we call the struvite stone. These patients, these stones happen in those patients because of an infection with some bacteria that we're going to talk about later. Did you see? Can you identify that this patient has an infection? Not really, honestly. He is vitally stable. He's not feverish, and which is why, like these, it's not showing a picture of the magnesium ammonium phosphate stone. Lastly is cysteine. Cysteine is could be one of the causes of and one of the constitute of a kidney stone in this patient. However, cysteine is very rare. It's a very rare, cysteine stones are very rare, which is why we don't usually put them on our list. As we put them in our list, but like in the bottom, we don't put them in the top as one of the important constitutes of those kidney stones. Now, let me just show you a little bit about kidney stones. Probably you guys saw it in Muhammad Al-Fuwais's lecture. However, I'll just go through it quickly. The first type of stone is calcium. We have calcium phosphate and we have calcium oxalate. So calcium oxalate happen in the cases of hypocitraturia. Why? Because usually citrate binds calcium. Okay. In cases of hypocitraturia, calcium will be free, which would allow it to bind to oxalate in the urinary system, causing the formation of calcium oxalate stones. X-ray findings are radio opaque. CT is hyperdense, so it shows on both X-ray and CT, and it's important for your pathology to know the shape of the crystals that are going to form, okay? And here we can see that it's basically the most common kidney stone, which is basically around 80% of the patients. Tamam? Now let's move on to the next one, which is basically ammonium magnesium phosphate. It's associated with high urinary pH. It's radio opaque as well as hyperdense, similar to the calcium oxalate. And then we have the coffin lead urinary crystals. It's important once again to know the description because you might get them in any of the questions in OSPI or in the MCQs. Why does it happen? Is that because of an infection with urease positive bugs. Urease positive bugs such as Proteus mirabilis, they have this enzyme, they have this enzyme called urease, which converts urea to ammonia. And as we all know, ammonia is alkalotic, which would cause urinary alkalinization, which would result in the precipitation of these struvite stones, or as you guys call them, staghorn stones, which are found in the renal pelvis. Thirdly, we have the uric acid stones. They are basically found in a urine pH of that's low, that's acidic. They are radiolucent on X-ray. You remember when I told you that in X-ray there are some stones that don't show? This is one of them, which is the uric acid stone, which is why we use for it the CT scan. They appear as rhomboid or rosettes, and they are only 5% of all the stones, and they are found in patients who have gout and have hyperuricemia. Lastly is cysteine. Cysteine is associated with low pH. Um, Shape is hexagonal. However, here the shape is rhomboid. Okay, so just like try to memorize this. How do you memorize it? Hexagonal is like it's a 6 sides, and cysteine it's similar to 16. So 16 with 6 sides is basically hexagonal. Here's a mnemonic by first aid book. Cysteine basically stones happen due to a mutation, which is basically an autosomal recessive genetic disease, which would result in a defect in the transporters for these amino acids. One of them is the cysteine. So this is basically the kidney stones in a nutshell. So the most common kidney stones are calcium oxalate kidney stones. Now let's move on to the third question. A 54-year-old man comes to the ED because of 3-hour history of severe left flank pain that radiates to his left lower abdomen. The pain begins while he was shopping for groceries and has steadily increased. Has never had similar pain. He does not have chills, nausea, dysuria, or hematuria. He appears anxious and restless. Vitally stable. Therapy with ibuprofen is started, and the pain decreases after 1 hour. A CT scan they did showed a stone measuring 4 millimeters in the diameter in the left proximal ureter. Which of the following is the most appropriate next step in the management? Please pause the video and try to answer it. So the answer for this question would be B, recommending fluid intake and discharge the patient. So just before I explain the answer, this is basically a case of a patient with a kidney stone, and the kidney stone they saw it on the non-contrast CT, and it measured 4 millimeters in diameter. So it's important to know the measurement and the size of the stone so that we can basically plan the management. Okay. Now let me just show you and walk you through the different management plans. Or actually, I'd like you to answer the next question and then I'll explain the two questions because both of them are management. If I explain it now, I would ruin the other question. So try to answer the question now. A 49-year-old woman presents to the ER suffering from severe flank pain. For the past 4 hours, vomiting. She has been experiencing dysuria and fever for the past 2 weeks. On examination, she has costovertebral tenderness, urinalysis, significant hematuria. Microscopic examination of the urine shows crystal with a coffin lid-like appearance. Which of the following is the appropriate treatment for this patient? Pause the video and try to answer. So the answer would be A, percutaneous nephrolithotripsy. Why is this the case? we will talk about it now. So first, let me just put for you this slide and to talk about the management of patients who present with kidney stones. Let's imagine that we're sitting in the ER department, and then we have a patient that's walking into the ER, complaining of typical loin to groin pain. He's a male, 30 years old. When asked, and the patient looks in very, very pain. And when you ask what is the pain, it's loin to groin. So the first thing that would you do for this patient is that you would start them on analgesia. Give them some analgesia. Why? Because we want them to calm down a bit so that they can explain to us the history and so that we can do the physical examination. Because otherwise you won't be able to do that. Once they calm down, you would start by taking the history and then doing the physical examination. Okay? Doing the physical examination. And then you will identify that might be a case of kidney stone. Then what would you do? Which type of imaging? We said that it's going to be the non-contrast CT. You did your non-contrast CT and saw a stone. Now let's talk about the management of these stones based on their size. If we have a stone that is like around 5 to 6 millimeters, now the management for this stone would be conservative. Why? Because this stone is a little bit too small that it can be expelled through the urine on its own. So what would they do in this case? The management would be conservative, using analgesia and advising the patient to be hydrated and drink fluid up to 2 liters a day. We can also give them a medication. It's an alpha blocker, which an example of it is tamsulosin. This alpha blocker would result in relaxation of the smooth muscles of the ureter, and this would allow the stone to pass smoothly and to be expelled smoothly while urinating. So this is basically if we have 5 to 6 millimeter kidney stones. Now, if we have kidney stones that are less than 2 centimeters, or we call it 20 millimeters, guys, see it here, it's millimeters. Here it's millimeters, and here it's centimeters, which might be confusing. I still remember it was confusing for me while I was studying in third year. So just memorize it as 20 millimeters, okay? So here 5, 6 millimeters, and here 20 millimeters. If you have a stone that's less than 20 millimeters and more than 5 to 6 millimeters, then your management plan would be ESWL, which is I think shock corporeal something. I forgot the exact name because it's a little bit hard, honestly. And so it's going to be this ESWL, or it's going to be or using basically ureteroscopy and endoscopic lithotripsy. By ureteroscopy is that they use a scope and go through the urethra all the way into the bladder, and then they can go all the way into the ureter and see the stone. So this is basically the management plan for the stones that are less than 20 millimeters and more than 5 to sorry, it's like this. Yes, more than 5 to 6 and less than 20. Now let's talk about the last management plan, which would be percutaneous nephrolithotripsy, as we saw in the last case. And this we can do it for the cases where we have very large stones, which are basically larger than the 2 centimeters or larger than the 20 millimeters, and complex stones. An example of the complex stones is struvite stones. Okay, what are struvite stones? These are the staghorn stones, which they are found in the ammonium, magnesium, which are basically ammonium magnesium phosphate stones. Okay, now let's go back to our question and see. Here in this question, we had a 4 millimeter in diameter. So what would be the management? It would be conservative. We would discharge the patient on the analgesics and on fluid and give them a medication, tamsulosin. Sometimes they give, sometimes they don't, but give them a medication called tamsulosin. Why? To enhance the ability of excreting this kidney stone. However, in this question, if you notice, this patient had severe flank pain, and this patient also experienced dysuria and fever for 2 weeks. So it's showing a picture of infection. Am I right? So which would be most likely infection with one of the bacteria, for example, the Proteus mirabilis. Okay. And also in microscopic analysis, it's showing coffin lid-like appearance. Let's go back to our table here. The coffin lid-like appearance is the ammonium magnesium phosphate, which is a struvite stone, or we can call it as a staghorn, because it's very big and very complex. So what would be the management plan? It would be percutaneous nephrolithotripsy, as you can see here, basically. Percutaneous nephrolithotripsy. Now, this is basically how to manage people with kidney stones. I hope it was helpful. And if you have any questions or if you got confused, you can email me whenever you can. Whenever you want, I mean. Now let's move on to this question. What is the single most important factor in the prevention of kidney stones? I know this question might be a little bit easy, but we got it in our exams, and some of the students would get it wrong because they might not read all the options, sorry. So pause the video and read all the options. The answer is D, increasing fluid intake. Now, I know that like A can work, C can work, B can work, B, C, and D, they all can work. However, the question is asking about the single most important factor in the prevention of kidney stones. And the most important factor is basically fluid, increasing fluid. Especially in areas where there is basically a high chance of being dehydrated. For example, here in Saudi, because of during summer, it's very important to increase the fluid intake. So here is basically a slide from your presentation. It's basically showing what are the methods to prevent the episodes of kidney stones. One is to increase the urine output to 2 liters per day. Others include, for example, decreasing sodium intake, decreasing meat intake as well. Why? Because they have an effect on the pH and the uric acid levels, which might precipitate uric acid kidney stones. Here, basically, decrease sodium intake. Why? Because sodium enhances calcium reabsorption. Whenever we have a high calcium, this would enhance the probability of having calcium kidney stones. It's important to note that one of the dietary modifications is not to restrict calcium. Why? Because calcium in the gut binds oxalate and result it's basically in them being excreted. And this won't be throughout the urinary system, which would basically decrease the chance of having calcium oxalate kidney stones in the renal system. Now let's move on to this question. A 25-year-old newly-gravid woman and her 34-year-old husband come to the physician because they have been unable to conceive for the past 6 months. The woman reports having regular menses at 30 days interval. Her last menstrual period was 3 weeks ago. The man had uncomplicated gonorrhea. Both take vitamins, no other medications. Physical examination shows no abnormalities. Urine pregnancy test is negative. Which of the following is the most appropriate next step in the management? Now, I want you to pause and try to answer the question. So the answer for this question is D, reassurance and follow-up after 6 months. Some of you might be confused. Why would it be D? However, I think you might not have paid attention to this important information. So the woman and the husband have been trying to conceive for the past 6 months only. 6 months. Okay. Do you guys remember what was the definition of infertility? Yes. Infertility is, oops, sorry. Oh, I show. Uh, if you saw it, it's fine. However, let me just show you it's in the other slide. So let me just tell you what's the definition of infertility. Infertility is basically not being able to get pregnant and to conceive after doing sexual intercourse without any barriers for 12 months. And this patient has been trying to conceive for only 6 months. So it's not considered as infertility. It's not considered as infertility, which is why we don't do the usual test that we would do for the infertility. So what would we tell the patient? Reassurance. Tell her that infertility is diagnosed after whenever there is basically after 12 months, after being unable to conceive after 12 months, and tell her to follow up after 6 months. Why? So that 6 plus 6 can give us 12 months, okay? Some of the things that you might tell the patient, for example, like using barriers, because some of them might not be educated enough. So you can tell them that using barriers would decrease the chance of basically being able to conceive and these stuff. So this is basically the answer for this question. Make sure to pay attention to the details in the questions so that you don't get such questions wrong. Okay. Now the same scenario. So here we have the same scenario. However, this patient was now unable to conceive for the past 12 months. Now we can say that this might be a case of infertility and further investigation is needed. Of the most appropriate first steps in the diagnosis of infertility is taking history. After history, we perform physical examination. So here they took history, they performed physical examination, which showed no abnormalities. Tamam? Tamam. So now what would be the appropriate next step in the management? Pause the question. Yes, the answer is semen analysis. So why would it be semen analysis? I think some of you might have chosen B, some of you might have chosen C. But trust me, when I saw this question, I also got it wrong because I was not expecting the answer to be semen analysis. However, in the algorithm of infertility, of diagnosis of infertility, semen analysis of the male husband is of the top differential diagnosis it's on the top of the algorithm for the diagnosis of infertility. Why? Because semen analysis is not invasive. You don't have to take blood, you just have to take the semen. So it's not very invasive, which is why it's considered as in the top of the algorithm, which is used to diagnose cases of infertility. So whenever you saw a case of infertility, of the most appropriate first steps is doing semen analysis. Now, after doing semen analysis, we would go ahead and measure the serum testosterone, FSH, as well as measure prolactin. Here, D is wrong because, as we said, here the patient has been trying to conceive for 12 months, so D is wrong. And then E. E here is basically like it doesn't have testing for gonorrhea and chlamydia is not of great significance when evaluating for infertility in such patients. And especially it's mentioning that the male he is the one who had gonorrhea, not the female. Females, when they have gonorrhea or chlamydia, which might cause pelvic inflammatory disease, which might basically have a complication, which is infertility. However, it's basically not in the case, and it's not in our scope for this question, so it's not going to be the answer. So the answer is semen analysis. Infertility is the failure to conceive after 1 year of proper trial, and 10 to 15 of couples are actually, unfortunately, infertile. This is basically from your presentation, by the way. Now, let's move on to this question. A 42-year-old bodybuilder presents to the clinic with a 2-year history of infertility. Past medical history, not significant. Admits to use long-term anabolic steroids and recent cessation 6 months ago. He has a well-developed musculature, bilateral testicular atrophy, and no varicocele is palpable. Semen analysis reveals azoospermia. This is basically his lab analysis. What might be the cause of his infertility? Pause and answer. So the answer would be C. Hypogonadotropic hypogonadism secondary to anabolic steroids use. Now, as you guys can see from the question, is that this patient is a bodybuilder and he has been using anabolic steroids, okay, for a very long term. And on physical examination, he has bilateral testicular atrophy, which is abnormal. And also there is azoospermia in the semen analysis. Here, when doing FSH and LH, we notice that FSH is low, LH is low, testosterone is normal to high, prolactin is normal, sorry. So what would be the cause? The cause here is basically due to the use of the anabolic steroids. Whenever we use external steroids, it can cause, let's say here. So when using exogenous steroids, for example, testosterone, it would cause a negative feedback inhibition on the GnRH production, which from the hypothalamus, and also it would inhibit the production of LH and FSH from the anterior pituitary gland, resulting in a hypogonadotropic hypogonadism. Okay? Because of the less LH, less FSH, less stimulation of the testes, this would result in them being atrophied and also would result in decrease in amount of sperms that are going to be released and produced by the testes. Which is why here in the question, we can see that this patient had bilateral testicular atrophy, bilateral on two sides. So it means that there is something systemic that's causing the bilateral testicular atrophy, not on only one side. Other than the bilateral testicular atrophy, there is azoospermia. Other than the azoospermia, FSH is low, LH is low, which means that there is something that's causing the negative inhibition because here testosterone is normal or high. So, which indicates that there is something that's causing a hypogonadotropic hypogonadism. Okay? Now let's rule out the other answers. So let's start with the obstructive azoospermia. In obstructive azoospermia, you would see azoospermia, that's true, but you won't see bilateral testicular atrophy. And if you see bilateral testicular atrophy, maybe in some of the diseases you might see it. However, let's take a look at the labs. FSH and LH would be normal in obstructive azoospermia. They won't be low, which is why we can rule it out. Let's go to B, non-obstructive azoospermia due to primary testicular failure. Why is this wrong? Because if the testicles fail, let's see here, if the testicles fail, they won't produce testosterone, right? So there will be less testosterone, which means that there will be less inhibition. Whenever we have less inhibition, this means that there will be increase in the production of GnRH, and because of the increase in GnRH, there would be increase in FSH and LH. And we would see in the lab analysis that FSH is high and LH is high. However, in our patient here, the FSH is low and LH is low, which is why we can cross it out. Klinefelter syndrome, it's kind of similar to primary testicular failure. Klinefelter syndrome patients might have atrophy, which would cause azoospermia. However, the FSH will be high because of the atrophy of the testicles, and the LH will be high, which is basically not in our patient here. So we cross it out, and the answer is C. Now, this question. A 32-year-old man and his 29-year-old wife come to the physician because they have been unable to conceive despite regular unprotected sexual intercourse for 13 months. The woman reports regular menstrual cycles. They don't have any history of serious illness or takes medication. Examination of the scrotum in standing position shows soft bands palpated in the upper pole and the left scrotum with an intact left testicle. Following Valsalva maneuver, the patient reports a dull, aching pain in his left hemiscrotum. When a light is held behind the scrotum, it doesn't shine, and the right scrotum is normal. Semen studies show normal sperm count with moderately decreased motility and abnormal morphology. Which of the following is the most likely diagnosis? Please pause and try to answer. The answer for this question is varicocele. Now, why is it varicocele? Let's just go ahead and see the clues that we have in our question here. So let me use the highlighter. Okay. So here we have a patient who's basically trying to conceive for 13 months. So here we have a case of infertility, okay? What did they do is that they took the male patient, and then they did an examination, and physical examination of the scrotum in standing position. There was soft band palpated in the upper pole of the left scrotum. Okay? Which is basically increasing in the case of Valsalva maneuver and causing pain. Whenever a light is held, it doesn't shine through. So this is basically suggesting that we might have a case of varicocele in this question. Let me talk about why is it varicocele and not the other options. Let me just explain to you varicocele. So varicocele is a disease where we have, it's basically a condition where we have the testicles are connected to the pampiniform plexus of veins, which are found basically in the scrotum. So whenever this pampiniform plexus of veins gets dilated, what will happen is that there will be more blood, okay? And more blood, and it will be more tortuous, and this would cause basically the tortuous, and because more blood dilated tortuous, it would be a bit larger, which would cause basically the soft bands to be palpated in the upper pole of the left scrotum. So this is basically their texture. And then it's basically a soft mass, which is basically when doing physical examination, you would like comment on it as a bag of worms. تمام. تمام. It decreases in supine and increases with standing. Why is this the case? Because whenever someone is standing, you guys know that there will be pooling of the blood in the veins. Whenever there is pooling of the blood in the veins, I told you that the pampiniform plexus is dilated, so there will be more blood in these veins, which would cause in them being larger and larger, which would basically cause the mass and the bag of worms. Same with Valsalva maneuver, because you're increasing the pressure, increasing intra-abdominal pressure, which would basically be causing compression on the veins, and then causing pouring of the blood backwards in the pampiniform plexus, which would cause basically larger pampiniform plexus and varicocele. In supine position, whenever someone is lying supine, the blood is going to flow easier towards the heart. So the blood is leaving the pampiniform plexus of veins, which is basically causing the varicocele to decrease in size. So varicocele, whenever we have a primary varicocele, it should decrease in size when supine and increase when standing. Now, let me ask you a question. What if we have a case when we have an increase in supine position and increase in standing? This means that it's not a primary varicocele and there is something wrong that's happening. What might be this something wrong? There might be a tumor, or basically a mass that's compressing the vein. So let's say that this is the pampiniform plexus of veins, okay? This is pampiniform plexus of veins. It's emptying into this vein. Tamam? Tamam. Let's say that we have a mass over here. This is basically a mass that's obstructing the drainage. What will happen to the blood? It will accumulate here, causing it to be larger. Now, if the patient lies supine, the mass won't change its place. If the patient is standing, there's nothing going to happen. So that's why if varicocele is persistent in supine position and standing, this indicates that there is something wrong that's happening and we have to investigate more. تمام? How to diagnose varicocele? Doing physical examination, noticing bag of worms, and then what would you do is you would, as they did here basically in the question, you would shine a light. Why? To differentiate varicocele from hydrocele. This is hydrocele. Okay? So we need to differentiate between them. Hydrocele is the fluid accumulation in the scrotum. When you shine a light through fluid, there will be basically, you would notice that when you shine a light through the fluid, you would notice that you can see the light. Tamam, clear? And this is basically positive in the case of hydrocele. However, in varicocele, because it's not fluid, it's more of a blood and thickened and it would be enlarged. This would cause basically the varicocele not to shine. So here we can see that it did not shine. So we can rule out hydrocele. Okay. Now let's go back here. So we said that we can do the the transillumination light test and also ultrasound. In ultrasound, what we are going to see is that there would be retrograde venous flow. Why is this the case? Because I told you that because they are dilated and they are tortuous veins, which would decrease the chance of the blood that's in the pampiniform plexus to leave and go all the way towards the heart. That's why it's associated with retrograde venous flow, and the veins are tortuous and they are dilated. So these are the findings in the ultrasound. Treatment, I'm not sure if you guys take it or not. I'll just go over it quickly. It depends on the patient. If the patient is a boy or a young man and they want to conceive, what would we do is that we would do gonadal vein ligation. However, if it's happening in an elderly man, they don't want more children, then it's fine. We can just give NSAIDs and scrotal support. What would varicocele cause is that varicocele, as I told you, because there is more blood in the pampiniform plexus and the blood is relatively warm. So whenever there is an increase in the temperature around the testicles, this would basically make them to be damaged and would result in testicular atrophy and which would cause basically infertility. تمام؟ تمام. So let's go back to our question. The answer here is varicocele. We ruled out hydrocele. Inguinal hernia, it won't present with these typical physical examination, which is the light held does not shine, and also varicocele is more prominent in standing, more prominent in valsalva. Inguinal hernia won't have this kind of typical presentation, so we can rule it out. And then we are left with A and B. A and B both are almost the same because in A and B there are no sperms. And here we can see that the semen analysis showed that there is normal sperm count. So that's why we can just cross them out. And the answer is varicocele. Now let's move on to this question. A 63-year-old man comes to the physician because of a 3-month history of fatigue and constipation. He reports having dull pain in the left portion of the mid-back for 2 weeks that has persisted despite taking ibuprofen. His father died of prostate cancer at 70 years of age. So there is pain, there is fatigue in a 63-year-old man. The patient has smoked 1 pack of cigarettes for 45 years, so he's a smoker. Physical examination shows left-sided varicocele in supine and in standing. There is also left flank mass. Rectal examination shows symmetrically enlarged prostate with no masses. Lab studies shows RBCs in the urine. Which of the following is the most appropriate next step in the management? So I want you to pause and then try to answer. And the answer is A, abdominal CT. Why is this the case? Here, if you can just go through the scenario. So this patient is 63-year-old, okay? And he has dull pain that has been there for 2 weeks. Clear? Clear. So fatigue, 63-year-old man with pain. He's a smoker, which is basically a risk factor for a lot of things. Now, on physical examination, which is the most important, is that there is varicocele, and notice that it's in supine and standing. Do you remember what I told you before? So if we have varicocele in supine and standing, this might increase the suspicion of having a mass lesion, basically. And then on physical examination, they basically found a left flank mass. So now we have a patient who has pain, mass, he's a smoker, and there is RBC in the urine. What are we suspecting in this case? We're suspecting a renal mass. تمام? So what would be the most appropriate next step in the management? For the diagnosis of renal masses, we can do 2 things. Either abdominal CT or, of course, it's with contrast, okay? So with contrast. So we do abdominal CT with contrast or ultrasound. So now let's see here. It's scrotal ultrasound. No, it's not scrotal ultrasound. We would perform renal ultrasound. Would you do urine cytology? Would it be of great significance here? We already did urine analysis and saw RBCs in urine, so the cytology won't be of a great benefit at this stage. Chest X-ray, there's no indication for chest X-ray in this patient. Renal biopsy. Now, would you do renal biopsy for a renal lesion? I would say no, unless it's very indicated. Why we don't usually do a renal biopsy in patients with renal masses? Because renal tumors, whenever you do a biopsy and insert a needle, they're very hemorrhagic. So they might bleed out and cause a lot of complications. One more thing is that if you insert a needle, this might cause tumor seeding. What do I mean by this is that if you insert a needle into a mass that is malignant and then you remove the needle, the malignant cells will be attached to this needle. So if this needle touches anything, it would result basically in these tumor cells to go everywhere. So which is why we don't usually do a renal biopsy unless it's very indicated. For example, if we're very not sure of what's going on, what is this mass, is it an abscess, is it not, then we would do in this case renal biopsy. However, if they put it in the answers, it's most likely they're putting it there to like make you confused. So go with the abdominal CT with contrast or an ultrasound. Just a quick overview of renal cell carcinoma. You probably took it in your pathology. it basically originates from the proximal convoluted tubules. Now, why does it cause varicocele? Is that, as I told you, it's causing a mass lesion that's invading the renal vein, which would cause basically varicocele if it was on the left side. تمام? Why? Because the left side empties into the renal vein and then into the inferior vena cava. So here in this patient, we had it in the left side. So see, left varicocele in supine and standing. This has greater suspicion of renal cell carcinoma. It presents with the triad, which is a hematuria, flank pain, and the palpable mass, which they all of them, they were there in our question scenario. It's associated with PAIR, which is basically PHRP, ectopic EPO, STH, and renin. You probably covered them with the FUAs, so I won't go over them into more details. So this is basically a typical presentation of renal cell carcinoma. Of the most common risk factors is basically smoking, and they happen in males in 50 to 70 years of age. Now let me show you this. Question: a 60-year-old male presents with hematuria, left-sided flank pain, and an unintentional weight loss of 5 kilograms. Over the last 2 months, physical examination reveals a palpable mass in the left flank. Laboratory tests show normal renal function. A CT scan confirms a 6 centimeters mass in the left kidney, highly suggestive of malignancy, with no evidence of metastasis. So what was the most appropriate next step in the management? So here, what did they do is that they did, there is a patient with the left side flank pain, weight loss, 60 years old, male. We have a palpable mass. Okay. CT scan confirmed that there is a 6 centimeters mass in the left kidney that's highly suggestive of malignancy. So here this is a case of basically a renal tumor. What is the most appropriate next step for renal tumors? So once you do CT scan and kind of confirm the diagnosis of renal mass, you would go ahead and do staging. After the staging, they would discuss the management plan, and the most commonly and the most appropriate management plan is to do what? Radical nephrectomy. So basically, this is the answer. It's radical nephrectomy. I remember I saw it here in your slides. So in your slides in the clinical presentation, it says that surgery is the mainstay of treatment. And what's the treatment of choice? It's basically radical nephrectomy. So if they put partial nephrectomy, percutaneous biopsy, or chemotherapy, just try to not be confused and memorize it as radical nephrectomy. Tamam? Make sure to know that radio and chemo have no role. As opposite to, for example, seminomas. Seminomas, we can use radiotherapy, if you guys remember, and now we will see it. However, in renal carcinoma, radio and chemo have no role. So that's why we can cross out D. We already talked about why we don't do biopsies. And then we're left with A or C. A is basically the treatment of choice. Now, with this question. A 25-year-old man comes to the physician because of a right-sided painless scrotal swelling. Painless scrotal swelling that he noticed yesterday while taking a shower. He is currently sexually active with 2 female partners and uses condoms inconsistently. He immigrated to the US from Argentina. He has smoked 1 pack of cigarettes for the last 5 years. Testicular examination shows a solid mass in the testes that is firm and non-tender. A light does not shine. The mass is not reduced when the patient is in supine position. So the remainder of the examination shows no abnormalities. Which of the following is the most likely cause? So pause the video, guys, and try to answer. The answer is yes, testicular tumors. Now, why is it testicular tumor? The first of all is that let's notice the physical examination. The mass is firm. It is a firm mass that is non-tender and it does not shine. Okay? So some of you might suspect varicocele, some of you might suspect tumor. Now let's move on. The mass is not reduced when the patient is in supine position. Sorry, yes, we're here. So the light held behind the scrotum does not shine. So since it does not shine, we can rule out hydrocele, okay? So let's rule out hydrocele. The mass is not reduced when the patient is in a supine position. In a patient with varicocele, with basically a testicular mass and the varicocele, would it be reduced in supine? Yes, it would be reduced in supine position. So we can remove varicocele. And one more thing in varicocele, if you guys can go back to the question of varicocele before, it says that the mass is soft. Here, the mass is firm. So firm masses are more suggestive of tumors, okay? So we crossed varicocele, we crossed hydrocele, we're left with A and E. A and E, they are infectious causes and inflammatory causes. So they won't cause this presentation. They would be more of an acute presentation of a patient with very pain, very tender, fever. There would be fever also. So in this patient, we don't have any of these, which is why we would go with testicular tumors. Now, this is basically here. I put for you this table for the testicular tumors. There is seminoma, embryonal carcinomas, teratomas, yolk sac tumors, and choriocarcinomas. Now, I won't go into the details of this because you guys might have covered it in your pathology, and I don't want to make this video long. However, I want you to pay attention to few things. The first thing is the histopathological appearance. Okay, histopathological appearance, fried egg, Schiller-Duval bodies, and the others, which is basically here, Rinky crystals. Pay attention to these minor details, okay? And one more thing I want you to pay attention to is the what hormones or enzymes that might be elevated. So in this case of seminoma, PLAB is elevated. In embryonal, you can see HCG, teratomas, yolk sac, you can see AFP. So just pay attention to these minor details. Tamam? Tamam. Now let's move on to this question. A 23-year-old man presents to the clinic feeling a mass on his right testicle. The patient's history of presenting illness is unremarkable. On examination, there is a hard testicular mass on the right testicle. So we have a hard testicular mass in the right testicle and a 23-year-old man. Following biopsy and staging studies, it's revealed that the tumor is a seminoma. Which of the following is the best next step? Pause the video and try to answer. And the answer is B, inguinal orchidectomy with radiotherapy. Seminomas are of the most common testicular tumors that happen in males. And one thing that's that's basically interesting about seminomas is that they are radiosensitive. They are very radiosensitive. So whenever you have a testicular mass that is proven to be seminomas, the management plan would be inguinal orchidectomy, which is the removal of the testicle with the mass, followed by radiotherapy. And it's usually associated with treatment and treatment of the of this mass. So the answer here would be B, inguinal orchidectomy with radiotherapy. These seminomas, they are sensitive to radiotherapy, not chemotherapy, so we can rule out this. Here in C, transscrotal orchidectomy with chemotherapy. So because there is chemotherapy, we can rule out this answer. Observation and follow-up. This is it's a tumor, it's a cancer. So it's basically in a young patient. This patient will want to try to conceive. So if we leave it, it might lead to bad consequences. So A wouldn't be the answer, and they were left with B, which is inguinal orchidectomy with radiotherapy. However, for non-seminoma tumors, these non-seminoma tumors are not radiosensitive, so radiotherapy is not very effective in them. What would we do in this case? We can do orchidectomy. We can do also chemotherapy. This is for the non-seminoma. So make sure to differentiate between seminomas and non-seminomas. Now let's move on to this question. A 65-year-old man recently retired after many years in a job that involved exposure to aniline dyes, including naphthylamine. 1 month ago, he had an episode of hematuria that was not accompanied by any abdominal pain. On physical examination, there are no abnormal findings. Urine analysis shows +4 hematuria. Microscopic examination shows RBCs that are too numerous to count. The results of urine culture is negative. What is the next step of in the management? I want you to pause and try to answer the question. And the answer is A, cystoscopy. Why is the answer is cystoscopy? Is that because here we're suspecting a case of a urinary bladder etiology, which in this case might be a tumor. Why would it be a tumor? Because let's see the clues in this question. We have a 65-year-old male This is one, a risk factor. And this guy has been having exposure to dye, which is called naphthylamine. Naphthylamine is very highly associated with bladder cancer. So naphthylamine, and do you guys can tell me what other risk factor? Yes, it's smoking. So if you see smoking and or naphthylamine in an elderly patient, you should put bladder cancer as one of your differential diagnosis in your head, okay? Now, he had an episode of hematuria. RBCs were too numerous, no abdominal pain. So this patient has isolated, what we call isolated hematuria. What is meant by isolated hematuria is that there is only hematuria, no abdominal pain, no masses, and nothing is obvious. So whenever we see a patient, an elderly male patient with isolated hematuria and the risk factor of smoking or naphthylamine exposure, we should suspect bladder cancer as one of the diagnoses. What would be the next step? It would be out of these, it would be cystoscopy. Why is this the case? Because let me just show you here. In cases of hematuria, this is the paradigm or the algorithm that we use. Urine analysis, the first, you would do urinary microscopy and urine culture as well. Okay? And then, depending on these results, for example, in our patient, we only had isolated hematuria that was not associated with any other symptoms. So that's why we're suspecting bladder cancer. And what would be the diagnostic modality for bladder cancer? It would be cystoscopy. Cystoscopy. If we were suspecting kidney stone, we might do a non-contrast CT. You get me? So in this here, we can CT not because we're not suspecting stone. Insert a catheter. Catheters are usually inserted for patients who have not urinated for a long time, which would result in urinary retention and accumulation of urine in their bladder, causing a very uncomfortable and painful sensation. So this patient does not fit into this criteria, so we can rule it out. Renal ultrasound, okay, it might be considered. However, the picture here in this question is more of bladder cancer, which is why we can rule it out and choose cystoscopy. Now we have two more questions left. A 62-year-old man comes to the physician for the evaluation of nocturia and the weak urinary system. These symptoms began 1 year ago, but have progressively worsened over the past 6 months. He now wakes up 3 to 5 times every night to urinate. The patient has smoked half pack of cigarettes daily for the past 30 years. Digital rectal examination shows diffusely enlarged prostate that is firm with nodules that are non-tender in the posterior lobe. Urinalysis is within normal limits. PSA level is 6.5, which is above the normal limit. Which of the following is the most appropriate next step in the management? So we have a patient that is basically presenting with urinary symptoms of nocturia, weak urinary steam that has been developing over the past 6 months. Okay, so this indicates that these are basically of obstructive symptoms, which they are the nocturia, weak urinary system, urinary retention, for example, or dribbling, for example. And this patient is an elderly that's 62. He's a smoker. And in the digital rectal examination, they saw an enlarged, firm, not soft, firm with nodules. This is basically giving us a picture of a prostate cancer. When they did PSA, they found that it is basically 6.5. So what would be the most appropriate next step in the management? I want you guys to answer it. And the answer is C, exactly. So if you have a patient presenting with a picture of prostate cancer, you did PSA, it was high, and digital rectal examination suggesting prostate cancer. In this case, you will do C, which is basically rectal ultrasound guided prostate biopsy to confirm the diagnosis of prostate cancer. And this was taken from your slides, guys. So here we have the features include a hard nodule that are non-tender, which is basically here in our patient, they are firm that are non-tender in an elderly with obstructive urinary symptoms. So what would we do is that we did a PSA. PSA was 6.5, more than the normal ranges. And then what would we do is that to confirm the diagnosis, we proceed with transrectal biopsy, ultrasound-guided biopsy. Once we confirm the diagnosis of prostate cancer, we would like to do staging. What would we use for staging of the cancer? We would use MRI. Why? And bone scan. Because one of the most common metastatic locations of prostate cancer is the vertebral column. So that's why we can do bone scan to visualize any metastatic lesion, as well as MRI to see the invasion and the local invasion of this prostate tumor. تمام. So this is basically how to diagnose prostate cancer. I forgot to put a slide, but I want you guys to, you probably know, but to differentiate between BPH, benign prostatic hyperplasia, and prostate cancer on physical examination. BPH has soft, enlarged prostate, and it does not have nodules, okay? So make sure to know this. Now we're with the last question. So a 63-year-old man comes to the physician for a follow-up examination. 6 months ago, he underwent an ultrasound-guided prostate biopsy after a non-tender firm prostate that was seen on DRE. The results showed adenocarcinoma of the prostate and there was no metastasis. So the decision was done to do radical prostatectomy for a localized prostate cancer. So they did cancer removal. Now the patient is concerned about potential recurrence of his prostate cancer. Which of the following is the most appropriate study to monitor for disease recurrence in this patient? Pause and try to answer. So the answer is C. PSA levels are the lab levels that you would use to monitor the response to the treatment of prostate cancer. Here, the question is asking, what would you use to monitor the recurrence in this patient? It's basically the same. It's the response to the treatment or the recurrence of prostate cancer in the patient. We would basically monitor the levels of the PSA, and we would basically monitor the levels and see, are they increasing, are they decreasing, are they normal, and act based on the levels of PSA. تمام? So would you do bone scintigraphy? It's basically for metastasis. The patient did not have metastasis in the beginning, and if and is not complaining of any symptoms, any other symptoms, so it won't be of great benefit. Transrectal ultrasound is used for the confirming the diagnosis. Transrectal ultrasound guided biopsy is used to confirm the diagnosis of prostate cancer. So we don't want to confirm here. We just want to monitor if there is any recurrence. MRI of prostate is done for staging, so it's not the answer. And during prostate cancer antigen test, honestly, I'm not very familiar with what this is. However, what I know is that the PSA level is the one that's used to monitor the recurrence of the disease in those patients. So here, I want you guys to know the slide about PSA. Know that 4 is the upper limit of the normal. Know that it is produced by the epithelial cells, calcium, and it's a calcium-like protein. I think I remember that we got this word in our exam, so just try to memorize it. And know that it could be high also in BPH. So it's not very specific for prostate cancer. So which is why it's not used for the confirmation of prostate cancer diagnosis. It's rather than this, it's used to monitor the response to the treatment and to see if there's any recurrence. تمام? So I think for the treatment of prostate cancer, also I want you guys to know this slide. Know that the difference if the patient had a local disease. In a local disease, you would do most likely radical prostatectomy. That's such as the last scenario that we saw. In locally advanced cases, you would do radiotherapy and hormonal therapy. And if it's metastatic, you would mainly depend on the hormonal therapy. So make sure to pay attention to the question, the scenario in the question, to know what kind of modality you would use for the treatment of prostate cancer. And I think this was all. I wish you guys all the best in your final exam. Don't worry, inshallah, renal exam is one of the nicest exams in third years. And بالتوفيق inshallah. Just don't forget your adhkar, go through the questions quickly, try to answer them, and make sure that you make sure that you study well and prepare well and sleep well for your exam. So this is basically my email. This is my phone number in case you guys want to contact me for any question. مع السلامة.